Hello, my name is Dr. Alfredo To, and I'm a resident in Kendall Regional Medical Center. So our case is titled Misdiagnosed Migraine Headache as a Clinical Manifestation of Underlying Pericardial Effusion. So firstly, I would like to define a pericardial effusion. A pericardial effusion is the accumulation of fluid within the pericardial space and has been described as a physiologic complication of a primary pericardial disease, infection, or systemic autoimmune disorder. Common manifestations include shortness of breath, fatigue, chest discomfort, lightheadedness, nausea, and fever. It's important to know that atypical presentations do occur, and they can generate a hurdle for the diagnosis and the implementation of adequate medical management. Intractable headache as an isolated manifestation of pericardial effusion has rarely been reported. Inability for the cerebral veins to effectively drain into the right heart circulation given external compression by an expanding pericardial effusion has been hypothesized as the cause. Given the incidence of low specificity symptoms like an intractable headache, high clinical judgment is warranted to effectively diagnose and treat this patient population. So next we're going to go into details into the case. So this is a 49-year-old female with a past medical history of recently diagnosed migraine headaches who presents as a referral from her PCP office for intractable headache. Patient complains of a chronic headache since undergoing a dental procedure 1 month prior. The headaches are described as throbbing, bilateral, constant, and ranging from 5 out of 10 to 8 out of 10 in intensity. She was evaluated by her PCP and treated with Augmentin, Excedrin, and Sumatriptan for suspected acute rhinosinusitis versus migraine headache. On initial evaluation in the hospital, the patient was afebrile and hemodynamically stable. Vital signs were within normal limits, and the physical exam was only remarkable for a pericardial friction rub on auscultation. A chest X-ray was done, which was remarkable for cardiomegaly. EKG shows low voltage QRS. CT brain, head and neck CTA, and CT venogram were all unremarkable. Her labs were within normal limits. Given the findings of a pericardial friction rub, a transthoracic echocardiogram was ordered, and it was remarkable for small to moderate pericardial effusion, IVC plethora, pericardial inflammation, and moderately increased right to left ventricular interaction. Autoimmune panel was ordered, and ANA and anti-SSA/Ro antibodies were positive. The patient underwent a successful pericardial window, pericardial drain placement, and biopsy. Following the procedure, remarkably, the patient described complete resolution of headache symptoms. She was discharged on appropriate therapy with colchicine and ibuprofen for pericarditis and given referral for outpatient rheumatology evaluation. So the imaging seen in the center of the slide, initially we have the EKG, which shows diffuse low voltage QRS. On the second image, we see the accumulation of fluid within the pericardial space. And the third and fourth image are a sequence of imaging which show what is described in the case as IVC plethora, which is a lack of compressibility of the inferior vena cava with inspiration. This is assumed to be due to the decreased venous return into the right side of the heart. So pericardial involvement is the most common type of echocardiographic abnormality found in patients with lupus and is typically reported in greater than 50% of the patients. Hemodynamically significant pericardial effusion causing a cardiac tamponade is a rare manifestation, and the incidence is usually less than 2.5%. In many cases, pericardial effusion is an indolent manifestation and is found incidentally while undergoing cardiopulmonary evaluation. However, in the setting of progressive disease, a pericardial effusion can lead to right-left ventricular interaction and the development of a tamponade physiology. Since progression to tamponade can occur in patients with lupus-induced pericardial effusion, a high level of clinical suspicion should be maintained. Our case highlights how an atypical manifestation like intractable headache in the setting of a pericardial effusion can lead to the diagnosis of occult systemic lupus. While the American College of Rheumatology has established guidelines and criteria to aid in the diagnosis of lupus, it is essential to take a holistic approach in patients with individual manifestations that cannot be explained by an alternative diagnosis. While key manifestations can aid in the diagnosis of the latter, in this case lupus, clinical judgment, a thorough physical exam, and deliberation into patient demographics, sex, age, and race can guide diagnostic considerations. Thank you.